Today on the Relationship Renovation podcast, we're lucky enough to have the guest Dr. Sara Brungardt, who is the owner-founder of Calm OCD, which is a series of centers where they're treating OCD. And
they don't want to, but their brains are saying you have to, or you're not going to feel better.
She talks today about, what exactly is OCD and what is the difference between that and anxiety.
The obsessions and the anxiety are not the problem. The compulsions are the problem.
And talks about how they approach helping people.
On helping people feel uncomfortable emotions, feel that sense of urgency, and then not do a darn thing about it.
Hello, all, and welcome to the Relationship Renovation podcast. I'm Tarah Kerwin.
And my name is EJ Kerwin. And today we're very excited to talk with Dr. Sara Brungardt.
Yes.
She is the owner of Calm OCD, which is a center specializing in obsessive-compulsive disorder. She has centers in Tucson, Arizona, in Scottsdale, Arizona, and now in Sandy, Utah.
Correct.
Yeah.
Yes.
So
Thank you.
welcome.
Thank you for having me. Appreciate it.
You bet.
And just a little backstory. We brought Sara in today as a guest speaker because we had her in doing an in-service with our staff. And we were just compelled to have her in here because she has so much knowledge around anxiety and OCD disorders. And again, we love to teach our community psychoeducation around mental health issues. And so again, this is why you are here. We're so excited to have you and so grateful that you are here with us today.
When we had you into our office, it was just a lot of really specific information. Mm-hmm. And reframed us as clinicians of looking at things differently, but also even on a personal level, Tara and I were like, wow, like this is some really important information. So, I mean, maybe just start off for us, Sara, if you would, just, tell us about yourself and your pathway and your career.
Yeah, I think one of my missions now is to help other clinicians and other practices learn how to screen for OCD and hopefully bring people closer to a diagnosis. And then with the diagnosis, they can get the right care. And so I was first a therapist in 2011, and I did general mental health and then also specialized in eating disorders. Mm-hmm. And then I moved over to specializing in OCD in 2016. And it was at that time, my very first day of treating a very extreme OCD case that I was like, oh my goodness, this is what I'm going to do for the rest of my life. And I just found it so life-changing for the client, which helped me just stay motivated and stay consistent with the work and just have an extreme passion for it. And so it was really through that introduction of having that first client with extreme OCD. And at that time, I was seeing that client 3 hours a day. Wow. And so when you treat somebody at that level of severity, you're making a big impact on their life. And so I just kind of fell in love with the work. And now with managing the practices, I see my role kind of shifting over the years. And so one of the things I love to do is outreach. And with outreach, providing that education to others. Because I'm always very open about the mistakes I made early on in my career. I think back to clients I had in 2011 and I remember exactly everything about them. And I'm like, oh goodness, I missed it. That actually was somebody that had OCD and I was treating them improperly and I was teaching them how to do more compulsions and I didn't know. And so now that I know better, I have to do better and I have to help others understand the condition.
Well, and that was really important for me as a clinician because I've been doing this for over 22 years now. And I had such little knowledge of, I thought I knew what OCD was and how it looked. So when you came in, I've only grown now as a clinician, but like in 20 years to not even have that type of knowledge and maybe having done the misdiagnoses, like so thankful that you're using your passion now to kind of provide information to the world.
Yeah, and I think through that education piece, there are so many myths about what OCD is and what it is not. a lot of times we think of OCD as somebody that washes their hands a lot or checks the doors, and that's definitely some subtypes of OCD. But the main thing that we see at our centers is people struggling with mental compulsions. And so a lot of times we don't see that as OCD. That's not what we have learned to look for in school and different trainings. And so I think that's one of my passions too, is helping people understand how different OCD can look. Kind of the latest research indicates 1 in 40 people actually have OCD.
Wow.
And so, I think it's actually a good thing at the beginning when people are Googling their symptoms, because a lot of times people are like, OCD pops up. So if people are Googling intrusive thoughts, OCD is likely to pop up when they Google it.
Yeah. Well, I mean, we all have thoughts, right? We all have thoughts swimming through our head all the time. Maybe starting there, because it seems like that's the main thing you're tying right away to somebody who's out there listening is intrusive thoughts and obsessive compulsive disorder. So what are intrusive thoughts?
I think something to keep in mind, and it may be helpful for me to differentiate between just intrusive thoughts that we all experience versus intrusive thoughts and kind of an OCD diagnosis. So I always tell people we all get intrusive thoughts. Somebody without OCD, their brain is allowing that thought to come in, and they're able to say, oh, that's weird, and then go about their day. An example I give is I had an intrusive thought one time when my foot was on the brake, and I was at Fry's, and this older gentleman was passing in front of my car. And my brain, I do not have OCD, and my brain said, oh gosh, what if you hit the gas right now and hit him? And I was like, oh goodness, that's ridiculous. And then I parked my car and I went in and got my groceries. Somebody with OCD, what's going to happen is if they would get that same intrusive thought, their brain attaches meaning to that thought and has this sense of urgency to resolve it. And so if somebody had that same experience with OCD, their brain would be like, oh my gosh, why would you have that thought? You're a horrible person. Why would you even think that? And then they'd park their car, and then maybe they'd check to make sure they didn't run over the older gentleman. And then maybe they'd circle the block. Maybe they'd look for the older gentleman. Maybe they would turn on the TV late at night to see if it was in the news that somebody was hit. There's no resolution. It's just ongoing. It's never enough. Searching for that certainty that they didn't run over this gentleman.
Wow. So it almost seems like what you're saying is that the intrusive thought is just the stimulus. It's the thing that sets it off.
It's the trigger.
It's the urgency to resolve it that is really sort of.
It becomes a compulsion.
Thoughts. Wow.
Yes. And so the person would be maybe doing some physical compulsions in that example, but they would do some internal compulsions. So they'd be providing themselves tons of reassurance, possibly. They'd be convincing themselves, I'm a good person. I didn't do that. They would be mental reviewing the past, or they would be, oh goodness, it's endless. They would be going through the whole motion of the experience. Wait, I didn't hear anything with my car, and so I think we're good here. Tons of rumination.
Just replaying it over.
So when we talk about rumination, that's any type of problem solving. And so any type of search for that relief. And so that one, and then self-reassurance, oftentimes will tag team each other, so to speak, at the same moment, back and forth.
Yeah. And so I mean, how does it, for that person out here that's trying to understand it, like, does it resolve at any point? Because, I mean, the initial example you threw out to us was what people think of more as like, like locking the door over and over, or washing your hands over and over. But you're saying that there's internal and an external. Mm-hmm. There's things you do, but then there's also a thought process that's happening over and over. Is there resolution? So
I would say, in my experience, it depends. And I would be curious what we define as resolution, right? One compulsion, so a compulsion is any type of relief that the person is getting caused by the fear. So oftentimes, well, not oftentimes, primarily all the time, they're going to be having to do so many different compulsions over time just to get that relief. So I've seen where maybe somebody's triggered and they've done 20 compulsions and maybe they feel okay about the situation. And then their brain is like, okay, well, this trigger's more important. And so then it moves to another fear. Right. And maybe they're feeling okay about that past thing, but this new fear is the primary. But I've also seen in situations, and I'm not even exaggerating, I remember treating someone one time that was triggered by something when they were in high school, and I met them when they were close to 50 years old. And that one trigger terrorized them their entire life.
They were continuing to try to resolve it.
Continue to look for that relief. And that one in particular was in regards to something called false memory OCD, where they were convinced that they had done something horrible. And so it was all mental rituals. And for this person, it took them Googling their symptoms to figure out what was happening.
Okay. And isn't it true that people who do struggle with OCD, they don't want, the compulsions are not wanted.
They're looking, well, for the obsessions. So the obsessions are the fears, worries, and doubts. And so they oftentimes are trying to stop their obsessions, and they're trying to stop that uncomfortable emotion that comes.
Right.
It's important, I think, to also understand that with OCD, the person feels anxiety oftentimes, but they also feel a lot of other uncomfortable emotions. So guilt, shame, distress, fear, all of those different things are happening. And then they feel compelled that they have to do the compulsion. People are looking for any sort of relief, but they don't want to wash their hands hundreds of times a day. They don't want to shower 10 hours. They don't want to, but their brains are saying you have to, or you're not going to feel better. Like, this is the only option.
And then that's just the pattern.
Yes.
That completely wreck it.
Yep. So at the beginning of treatment, we do lots of psychoed, and people learn that the obsessions and the anxiety are not the problem. The compulsions are the problem in this OCD cycle that we build for them. And so they realize that they can have a different relationship with their obsessions, different relationship with those uncomfortable emotions, and ride it out without doing that behavior. And when I say behavior, mental and physical.
And so, one of the important things you talked to us about when you initially came in was about misdiagnosis.
Yes.
Is how like anxiety versus OCD. Can you really like speak to that? Because that leads to treatment, right? Like how a person addresses these issues. Like, what are the real differences between somebody who's suffering from anxiety and somebody who's dealing with OCD?
Yeah, when I train other therapists, I tell them that there's different things that they can look for, like in session. One of the things that comes to mind, if the same thing is happening and the person is not getting relief, there is just no relief inside, and they're just having the same conversation with their loved ones over and over and over, the same fears over and over and over. I also see a lot more of the term "what if," and so the OCD brain will see, like, what if I killed someone? What if I want to sexually molest a child? What if I did something bad? What if an intruder is going to break into my home? So I tell parents too to like look for that language. That happens some with GAD for sure, but not to the level. And I would say too, like the level of fear associated with OCD is different. Okay. I see the distress level much higher. And so, for example, with school avoidant cases, I'm always screening for OCD because that level of anxiety and fear is just amplified to the degree.
So again, I guess I want to, because anxiety can be like super overwhelming, right? Mm-hmm. Like, anxiety can cripple people, but it sounds like, and I just want to make sure I'm getting it right, that it's about the way in which they deal with the anxiety, that maybe general anxiety disorder is less like, there's less of an intense reaction to it.
Yeah. And it tends to be like more free floating, right? Like there are things that cause me anxiety in my life, but once they're over, maybe I have to do something, then it's pretty much resolved, right? Like I gave a presentation at a conference with one of our therapists, Amanda, and I had anxiety. Like that's a normal thing, right? Like it's important to me. But after the presentation was done, like I felt better. I got that relief because it was just an anxiety-provoking situation for my nervous system. With OCD, people are not getting that long-term relief. And so things like cognitive restructuring or talking it through are not going to be definitely helpful in the moment. Where somebody with anxiety, they can call a parent, they can talk through things, and they're like, okay, I get that. People with OCD, that may have short-term relief, but that obsession is going to come up again. Yeah. It's not really long-term relief.
And is it also just less general? The anxiety might be, like you said, like
OCD
sort of a blanket.
has themes, major themes we're looking at.
Okay.
And so there's definitely different subtypes of OCD, but there's also miscellaneous obsessions, and it's going to target things that are really important to them. And so it's fascinating too, since I've screened, at our clinic now, we've screened thousands of people for OCD, and almost always they're fitting into one of the major themes of OCD. So that's another thing we're looking at too.
One of the things that really stuck out to me as well when you were doing our in-service was like, I can't stand when people say I have OCD tendencies, right? And then environment versus genetics. And that OCD is genetic. It is not caused by environment, because I remember this question around trauma and how do we know if it's trauma related or OCD related? And I feel like you made it very clear that OCD is 100% genetic.
Primarily, it'd be incredibly rare that somebody would come in and their genetic background not have somebody in their family history with anxiety or OCD. The difference would be if they have PANS or PANDAS, a child getting that illness and then developing OCD as a result.
Say that one more time.
Yeah, it's PANS or PANDAS, oftentimes caused by strep throat infection.
Oh, okay.
We have a wonderful research team here in Tucson that does a lot of great work with that condition. And with that condition in particular, once you have the OCD, it does some damage to the basal ganglia. And so it is a lifelong condition.
And so it's set on by the virus.
By the infection.
Interesting.
Yep.
I had no idea.
Yep. But that is one of my things I love to educate people on, is the fact that during an intake, educate therapists on is during an intake, it's so important to understand the family history. And if they say, my mom's anxious, I want to know what that mom does in particular, and it's really enlightening. Oh, okay, that maybe sounds like a possible OCD condition that was never diagnosed.
Because most of our listeners are out there and they're trying to discover, hey, is this something that's that's affecting somebody I love or myself? I think that the idea of what are the major themes that you see popping up in OCD would be super useful.
Yeah. I think there's so many ones we could talk about. What's fascinating is I think my favorite to treat are like harm and sexual subtypes of OCD, because of just the amount of shame and guilt associated with those. It's always fascinating when I get our Google stats at the end of every month, and it says what is bringing people to our website.
Searching. That's cool.
The number one thing that is bringing people to our website is sexual intrusive thoughts. So when I think back to early on in my career, before I did OCD work, I did general work for 5 years. Never once did I have somebody tell me that they had sexual intrusive thoughts, not because they didn't, but because I didn't ask. And so harm and sexual, I think last I heard, it's the third most common subtype of OCD. So it's really important that we're spreading awareness about that subtype and how debilitating that is. With harm obsessions, it can be like the fear of harming self or someone else. And that can look so different. With sexual intrusive thoughts, it can be the fear that they're going to sexually rape somebody, fear that they're going to do something inappropriate. It can look like pedophilia, so a fear that they're going to molest their child or another child. I always make it very clear these people have absolutely no intent whatsoever to do these things. It's their brain giving them this obsession and saying like, maybe you will, or you will become this, or you're going to. And so I want to make it very clear these people have no desire whatsoever to do those things. Obviously, contamination, also a very common one. Checking compulsions are very, very common. Goodness, there's so many. Since we're on this sort of a podcast, relationship OCD is one that's kind of gotten some traction the past few years. And I've seen very severe cases of this, and it looks a little bit different depending on what the client is presenting with. But I've seen a lot of fears around maybe they don't love their partner, maybe their partner isn't the right one, fear that their partner's cheating on them, or a fear that they're cheating on them or going to cheat on them. There's also a really fascinating part of relationship OCD about where the person their brain will not give them any relief around obsessions that their partner maybe had a better sexual relationship with somebody else. And so they'll be terrorized by compulsions of just searching for relief and resolution. And so they'll be seeking reassurance from their partner a lot. They'll maybe want details about the former sexual relationships. I've seen this one in very, very extreme levels. I've also seen the fear of like accidentally flirting. And so then they have to go home and confess this to their partner.
And is it like just repetitive? Is it just like it just keeps, there's new data consistently coming
it's
in?
never enough. And their brain is like, here's evidence for this. Here's evidence for this. Where in reality, there really isn't concrete evidence, but their brain is making them very doubtful. OCD was originally known as the doubting disease, and I think that comes across in every subtype we see. I highlighted a little bit with the obsessions of relationship OCD, but the compulsions are really what terrorize people. And so say somebody has a fear that their loved one is cheating. This person may track their loved one's phone. They may check the bed sheets. They may text them nonstop. They may seek reassurance all the time from the partner that they're not cheating. They may call their parents seeking reassurance. They may look for evidence throughout the whole house for hours and hours and hours. They may follow their partner when they're driving. It looks like a very,
like jealousy,
toxic
or mistrust.
It looks like maybe a domestic violence relationship, something very toxic. But in reality, it's their OCD brain that it doesn't matter what their partner tells them, because their brain
There's no relief.
Correct.
Wow.
Correct.
Wow.
So that's one I've seen a lot. I see a lot of people, when we talk about OCD, we also have to talk about the level of avoidance people live. So I see people avoid relationships a lot because they're like, why would I even set myself up
would I want to go through
for
that?
my OCD to terrorize me, right? So they'll avoid dating. They'll avoid marrying. We've had people, finally get engaged, but be engaged for 10 years because of fears of actually making that commitment.
Yeah. And do you see that? So do you see people like they sort of switch from category to category, or do they generally just like, if it's around, if it's around contamination, they stick in contamination?
So like through somebody's lifespan, it's very, very common for it to switch. And so when we screen somebody, they'll say, oh, I had this one as a kid. Oh, I had this one in high school. That is going to be the most common. And then there's going to be several that they're typically dealing with in the current moment.
For some reason, I'm also thinking of like it's something that we talk a lot about here, and listeners bring up often as like postpartum and around once you have children and the obsession of safety. Is that something you see a lot about?
Yes, that's a good one. That one can be so debilitating, and people suffer so much with that. And I think it's a fear and anxiety that all new parents have, right? But the difference with somebody that meets the criteria for OCD is just kind of the exaggeration of that fear and how intense it is. And so if I'm a new mom, of course I'm concerned about SIDS. Maybe I'm concerned about some contamination stuff and germs, but it's not compelling me to a point where I'm not sleeping at night, right? People with this condition, they're checking the bed sheets, they're rewashing clothes, they're making sure something didn't drop on the floor and the toddler's going to get it. They're checking pictures on the wall to make sure that they don't fall on the child. It's just never ending.
Yeah.
It's never enough.
Now, do you see individuals where it's almost like manageable for a period of their life where they are able to sort of still function, get through life, but then there's something that triggers a point where it becomes like chronic?
Yes, I have. I'd say a lot of times if we look at just the lifespan, people will describe like middle school years as where they're going to have an uptick in symptoms, and young adulthood I've seen too. Sometimes we get people later in life, but a lot of times during those stages I've seen. Any times of like transition and different stressful transitions, like going to college, we get a lot of college students. Different transitions I see as something where it's a lot for the brain, and maybe they always had OCD, but it was manageable or it didn't present in a way that was truly debilitating.
Right.
I also see maybe, women who've recently had a baby where maybe they've had OCD, but it's been labeled as anxiety. And then they have a baby, and then all of a sudden they have sexual intrusive thoughts and all of these different things that they're like, oh my goodness, what is happening? This is not what I'm used to.
Well, and what's so important is, again, something that I heard from you during the in-service that you provided for our staff was educating therapists so we can properly diagnose, because talk therapy is not helpful for someone who is experiencing OCD.
Yeah. One of the things, my short answer to that is because I made the mistake early on in my career, a lot of times well-intended therapists will be teaching their client how to do more compulsions. And it makes sense. We're looking for resolution. Nobody likes to see our client in distress. What's interesting, though, with traditional talk therapy, oftentimes we're focused on anxiety reduction, right? Like we're giving very specific coping skills. And I'm not saying I don't love coping skills for OCD sufferers, but we have to understand when to implement them. And so I help people kind of understand that the reason they haven't had results in traditional talk therapy is the therapist is focusing on anxiety as the problem and looking for anxiety relief, where with OCD treatment, we view it as compulsions are the problem. They don't have an anxiety problem, they have a compulsion problem.
Yeah, that's so interesting, because especially, I know when I first got into the field, there was such a push for solution focus, right? And that is almost like what you're saying. It's like the antithesis of what somebody needs, because actually the solution focus is what they're already doing. They're trying to find a solution, but
we're
that's
focused
not the
on the wrong area.
Yeah.
Because when someone comes in and we start psychoed and I'm like, the obsessions are not the problem. The anxiety is not the problem. They're devastated.
Yeah.
They want a solution to resolution there. And I'll say, but there is an alternative. Once we start realizing that you can do the opposite of what your brain tells you can do, you don't have to do your compulsion. That's how you ultimately get long-lasting relief. Once we stop the compulsions, the anxiety will reduce on its own.
So we want to definitely get into treatment. Because I think that's what people want to hear about. Like, how does this get better if somebody I love or myself is suffering with it? But first, just for the sake of our audience, who most of you are out listening are here because, something's going on in your relationship. This is about your relationship. So if either a person is individually suffering with OCD or their partner is, what would sort of the byproducts do you think be in their relationship? Like, what would they be noticing is happening in their relationship?
The first thing I would say, any levels of avoidance of a lot of different things. So an example here, there's a subtype of OCD called sexual orientation OCD, where this person fears that they're physically attracted to the gender opposite of their orientation. Okay. So these people will intentionally have sex with their partner to check that they are indeed sexually attracted. or they'll completely avoid it because they fear that maybe that's going to give them a different answer. Yeah. So that's one thing that comes to mind is kind of the sexual activity piece. Also with sexual intrusive thoughts and the fear that they're going to rape somebody or be sexually attracted to a child or something like that. Sometimes that they will fear and avoid having sex with their partner because they don't want those thoughts to pop up during the sexual activity. And so I see that very, very common. Yeah, so it's either they're going to do it to prove that they are in fact this or that, or avoid it completely. Yep.
But I would think like for like a partner or somebody, especially with the sexually intrusive, it would be really like it would be almost easier in some level if your partner has like a contamination because you'd see them cleaning and you'd understand.
Could be outward.
But the sexual, how do you say it? The
sexual orientation,
orientation, or anything, or attraction or whatever would be really hard because I don't think you probably wouldn't share with your partner. Like
sometimes they do and sometimes they don't. I would say a lot of the times they have sought reassurance from their partner a lot or confessed their thoughts. And so that's kind of a caution flag, so to speak, if a partner is seeing that behavior and it's just ongoing. I've also seen partners, the OCD sufferer, leave their partner because they fear that, oh my gosh, I'm not attracted to them anymore. In that case in particular, the husband at the time had no idea what was going on because she didn't share that she was fearing she was no longer sexually attracted to him.
I'm kind of like thinking about the treatment here, but so you've used the word terrorized multiple times today. And I was sitting with a client who struggles with OCD, and the question was like, what would it be like if this wasn't a part of it? And there was just like, I would be free. Mm-hmm. So when you use the word terrorize, I feel like that's so appropriate because it's like you're just in a prison cage, like, and you can't get out, but you want to so bad. And so knowing that there is a treatment out there, because again, for me, even as a clinician, I used to think like, if you have OCD, you're doomed. Like, what's the treatment? Because talk therapy doesn't really work. And I've also worked with eating disorders where a lot of OCD was attached to that, but I always thought it was the eating disorder first, right?
Yeah, I agree. And I think, I remember having a conversation with a young man and he'd been in lots of treatment before. And he's like, okay, so you're telling me I got to give up my compulsions. And I'm like, yeah.
Kind of.
And he goes, so if I do that, like how long till I feel better? And I kind of reflected on it and I said, I think we'd come back next week and you'd be feeling better. And he just looked at me shocked because people believe that they're going to be in treatment a long, long time when they're going to OCD specific treatment. And that's just far from the truth. Our treatment is solution focused, but in a different way where, we go through that psychoeducation and then we build what's called a fear structure analysis where we're helping them identify all of those obsessions and the connecting compulsions. And then we start working through exposure response prevention on helping people feel uncomfortable emotions, feel that sense of urgency, and then not do a darn thing about it. And then they realize I can do this. And it's this confidence that happens, and it's this ripple effect. And they realize that the skills they're learning, it generalizes to every subtype of OCD they experience, right? And people are funny. They're like, oh my gosh, I'm going to be so overwhelming for you as a therapist because I have more than just contamination OCD. And I'm like, typically people are coming in with lots of subtypes. So what's cool about the skills is you can generalize to all of the subtypes.
So when you say exposure therapy, right?
Yeah.
In some level, is it like exposing them to the fact that they're okay not engaging in their urgency to resolve it, in their compulsion?
Right. So really the equation is their trigger, their obsession is going to come up, and then the exposure is to not do the compulsive behavior. So say that example of me and the gentleman at Fry's, if I had OCD, the exposure would be, okay, my brain gave me that message. And instead of doing all of my mental rituals and instead of physically checking the parking lot and getting on the news at night, I'm going to resist doing those behaviors. So that's truly what exposure is. I think exposure therapy gets a bad reputation because in ERP, so exposure response prevention, sometimes the focus is just on the exposure, but resisting compulsions is actually the most important part. And so, we do a mix where we do what's called organic exposures, where we teach people how to resist in the moment. So if you're triggered outside of session, here's the equation to resist. And then we also have people do purposeful exposures where, say, they have a fear of their loved one cheating on them, and we sit with the word cheating and we're eliciting that obsession and having them resist compulsive behavior. We have to do a combination of kind of the organic and the purposeful because that's how they build confidence. Mm-hmm. Because if people are battling with their OCD brain all day and we're only doing response prevention, that's not enough. We have to show OCD that we can do it. We can trigger ourselves. We can lean into that fear by doing these purposeful exposures too.
Well, that's because, especially if you're saying that this is like a genetic thing, that it's a way in which your brain just works. So it's not going to ever truly go away, right? It's just that your response to it changes.
100% gave me goosebumps because that's a beautiful way to say it. And I tell people too, what's cool about this is once you've had quality OCD treatment, you get to decide how big your OCD is and how much it takes over your life.
I love that.
You get to decide whether it's 90% of your life or 10% of your life. And I think when we get as young as 5 into our clinic, and we love seeing young people because this is missed so often that adults will go decades and decades and decades mm-hmm. suffering, where you actually don't have to suffer. You can learn to manage this. And I think for me, a true sign of healing as I train my therapists, what to look for in working with our clients, a true sign of healing is where people have a nonchalant and humorous relationship with their OCD brain.
Yeah.
And so I had a young man come in to a session one time, and I had met with him, intensively every day for several weeks. And he goes, "Oh my gosh, Dr. Sara, I can't wait to tell you the ridiculous thing my OCD told me this morning." That tells me we're exactly where we want to be. There's this separation that's happened. We're not with the OCD brain anymore. We've externalized it and realized, okay, that's weird. Oh, wow. You're creative. You're creative today, OCD.
Yeah. Oh, yeah.
That seems, I'm sorry, go ahead.
Well, I was going to ask, especially for parents listening and thinking about, right? I see children as young as 5. How would parents even begin to think about what if or what is what do you see in the differences of maybe just a child who's anxious versus who might
have OCD?
Having OCD.
Yeah, so I can speak to maybe what we see in kids a lot. It's very common for fears around just something generally bad happening. Their brain will be something bad is going to happen. They get a lot of fear of intruders at night, fear of the dark. A lot of times they'll do different nighttime rituals. They will do little prayers with maybe their stuffed animals mm-hmm. to confirm safety. They will ask their parents for reassurance that they'll wake up the next day. You're going to look for any sort of repetition. Yeah. An example too, I think of, say a kid watches a scary movie. And I think back to one that I was scared of as a kid. And I remember sleeping in my parents' room for a week because I was that was really scary. And it was actually Twister. I'm from Kansas. It's really not that scary, but at that time it
very
was.
Real, right?
But, it was my world. But the difference is with OCD, that young child isn't getting relief and they're not moving back to their bed in a week. Yeah. They're asking for reassurance about Twister. They're doing all of those things to try to maintain safety. The other thing would be just avoidance of things, avoidance of extracurricular, avoidance of school. one of the top subtypes of OCD we treat, and we treat it in kids all the time. We just put a blog on our website today, is emetophobia, the fear of vomiting. A lot of times kids will have the fear of choking. We have a fear of people looking at me, fear of doing something embarrassing, a fear that I'm going to do something inappropriate. I see that with kids a lot.
Thank you for sharing that.
Wow. Well, I mean, it feels like we're just sort of scratching the surface, and we'd love, maybe have you back sometime and talk even more about relationship and how it ties in there. But I feel like we've given our audience a real good sort of like what we honestly got a few months ago was just an introduction to looking at anxiety a little bit differently, and really looking at OCD and how it might be something we're not treating properly, but then also that it's something that can be worked with when you find the right clinician who's approaching it in the right way. And it's also a great way for us to sort of talk a little bit more about what you're doing. Could you tell us about your centers and where you are?
Sure. Our original location was in Scottsdale, and then that location's been open 3 years. And then we opened in Tucson last year. And then in Sandy, Utah, we opened last week.
Oh.
And so thank you. So we see all across the lifespan. I think our oldest right now is 75 and our youngest is 5. We treat a lot of co-occurring conditions. So we do treat, GAD, panic, misophonia, which is the issues with sounds. We treat hair pulling, skin picking, eating disorders, body dysmorphic disorder, everything kind of in that family we see. We also work with parents on a curriculum called SPACE, where we're helping them reduce family accommodating behaviors. And the terminology and the different things you can say to a child that's anxious. A lot of times we work with families and everybody is it's the sense of urgency, and it's a catastrophe when the child's anxious. And so we want to build skills in the child, and we can't do that until they're facing the things that are uncomfortable. And we have to continue to help them develop as humans so that they can feel a wide range of emotions, which is what I love about that curriculum.
And if somebody's interested, if they want to reach out to you, if they want to connect, like what's the easiest way for them to do that?
So our website, calmocd.com, is a great resource. We have tons of blogs, tons of articles on there, and they can submit an online inquiry or call our main office with our Scottsdale team.
I just want to say thank you for providing amazing knowledge and skills to the therapeutic community, but also to individuals and families who are struggling and suffering and maybe asking, could this be it? And really helping to differentiate between anxiety and OCD.
Thank you. Appreciate the opportunity.
Thank you, Dr. Sara. It's been a pleasure. And we'll definitely, we'd love to have you back on again and go a little bit deeper into this subject matter.
Of course.
And I just want to thank all of our listeners so much for being with us on this journey, and for, being invested in personal growth, in relationship growth. Please just give us a follow on YouTube or a like through your favorite podcast listening platform. Reach out to us if you have any questions. If you want us to ask any questions for Dr. Sara when she comes back on again, we'd love to have your input. So, thank you for being a part of our community.
And as always, take care of yourself, take care of each other. Bye-bye.